Hello everyone, my name is Dr. Toke Oke and I am pleased to welcome you to this year's Lupus Awareness Month Health Symposium themed Make Lupus Visible and hosted by the Laba Laba Foundation. Now the Laba Laba Foundation has been speaking on, discussing and promoting all things lupus related since its inception in 2018. Now normally this symposium would have been held in Lagos, but due to the COVID-19 pandemic, it has been moved online. The beauty of that is that we now have people from all over the world who can join us, and we have here with us today. So we've got doctors, we've got nurses and other healthcare specialists. We've also got patients, people who are living with lupus, their family and their carers, and they are joining us today as well. So you are all welcome. We have an expert panel of speakers today who are ready to share the wealth of their knowledge and their experience with us. So do sit back. There is a lot that we will be learning today. We will also have an update of the COVID-19 situation here in Nigeria by one of the officials from the Nigeria Center for Disease Control. And then we'll also be hearing from a patient, from someone who is living with lupus, who will be sharing her experience with us. As we go along, you can ask questions. If you go to the bottom bar on your screen, if you go to the bottom bar, you see a Q&A icon. And if you do have a question, we will be taking a couple of questions after each speaker has finished. You can pop your question there and it will be picked up and directed appropriately. So without further ado, I would like to go ahead and introduce our hosts and the co-founders of the Laba Laba Foundation, Mrs. Chisa Nosamiefen and Dr. Aisha Akinkwe. So Mrs. Chisa Nosamiefen is, as I said, a co-founder of the Laba Laba Foundation for lupus awareness and advocacy in Nigeria. She's also a member of the Patient Advisory Board of the Brigham and Women's Hospital Lupus Center in Boston, Massachusetts. Now, Mrs. Chisa was diagnosed with lupus over 20 years ago. As a mother of very young children at the time, it was a very challenging and gruesome time for her. So she understands the challenges and the intricate needs of those affected by lupus firsthand. As a lupus champion and advocate, she is dedicated to the global fight against lupus. Ladies and gentlemen, please make Mrs. Chisa Nosamiefen welcome.
Hello. Good day, ladies and gentlemen, depending on where you are. All protocols observed as I welcome our distinguished panel of speakers, lupus champions and their support systems, doctors, researchers, medical students, and the community at large to our Lupus Awareness Health Symposium 2020. I've always wanted to say that I hear all protocols observed at many Nigerian functions, so I've always wanted to say that. This year, our theme is Make Lupus Visible. Usually when we hear the word visible, and it's Lupus Awareness Month anyway, we always think in terms of, okay, we're going to talk about the signs and symptoms of lupus, who are those suffering with lupus, how do you get lupus, what is, what are, so we highlight the demographics of the people who have lupus and the kind of things that they're going through. But we're going to be doing something different today. When I talk about making visible, we're going to be hearing from experts in the field. We want to look at what is going on with lupus, what's going on with lupus in Africa, what is going on with lupus in Nigeria, and what is going on in lupus in general. We want to look, make it visible. A lot of work, there are millions of people that are adding. Today I'm going to be using a puzzle, a piece of a puzzle as my to illustrate what I'm trying to say. And we're going to be looking at the pieces of the puzzle coming together to make a big picture. And in doing that, we're going to see those pieces of puzzles, the building blocks that have been put in place so far. Before we go to that, I'd like us to take a moment of silence to honor and remember those that have gone, that have passed away, that had lupus, and especially those that have been a part of the Laba Laba Foundation that we've lost in the past 2 years. Cheryl was a mother of 3. Cheryl had a 7-year-old, a 5-year-old, and a newborn that was 3 months old. Her husband said to me, "We did everything right. We did everything we were told to do. We were told this was not a death sentence. What more could we have done?" She was in her 30s. Aishatu was a postgraduate student doing her master's in IT in Malaysia. She got so sick that she had to come back home. Aisha sent me a video at some point, and she said in that video, she says, "When I joined the Laba Laba support group, they made me feel like I was human again." Aisha was 34 years old. Somto Chukwu was 11 years old. For those of us that were at the symposium this time last year, Somto actually gave his story at that symposium, and he received a standing ovation. Somto also sent me a video, and in that video, something struck me. He said after many years of misdiagnosis and being in the hospital for so long, he left the hospital in December in 2017, sorry. And soon after, he joined the Laba Laba support group. And he said, "For the first time, I was relieved that there were others fighting the same fight that I was, this fight against lupus." Somto Chukwu also happened to be the recipient of the Odelia Pediatric Academic Scholarship, annual scholarship we give away. Last year, he was a recipient, last year in October. Eldera, a few weeks ago, as I was so disturbed with the fact that so many of the patients in Nigeria couldn't get their HCQ, and we started to find a way in which we could assist them. And I started to call them to find out if they had HCQ and how I could get HCQ to them. That's a hydroxychloroquine. And Elvira didn't answer her phone. I'd send texts and I'd send messages and she didn't answer. Elvira, I thought to myself, she's just like one of my children. They don't answer your texts. They don't answer their phones. Finally, I said, look, I need to find her mom's number. And I found her mother's number when I called. Elvira had just passed the Monday before. I wept. Because Elvira, all she wanted to do was to get her college degree. She was 19. She was in the University of Lagos, and she lived so far from school. It took her sometimes 5 days going to and fro to school because she couldn't afford to stay in the dorm. Elvira left us not too long ago, a few weeks ago. There's one other person. Her picture is not here, but I mentioned her when I spoke about Somto. Her name is Odelia. She's the first person I knew that passed away with lupus. Odelia was 13. Odelia used to be called the human encyclopedia because for many days when she couldn't go to school, Odelia would stay home and she would study everything. They would say of Odelia, anything you ask her, she knew because she studied everything, about everything. She wanted to be a neurosurgeon. Odelia passed away in Duke Hospital in North Carolina. A few years ago, she was 13. So because of Odelia, in honor of Odelia, that we have an annual scholarship for those who are suffering with pediatric lupus, that we can support them in a way to take some of the stress of their parents. Because of these ones, Laba Laba will continue to fight this fight until a cure is found. So today, as we listen to, next slide, please. So as we listen to our experts, we're going to be looking at the pieces of the puzzle. There have been many layers, many pieces, many people, many sectors, the researchers, the patients, the doctors, the governments, the institutions have been being put together to get to the place where we can find the cause, better management, and the cure. And today, as we listen to the experts, we're going to pull from them. And my takeaway for you today, or my hope of your takeaway today, is that you will be able to take one piece away and say, this is a piece I am going to bring to the table. It doesn't matter if you're a caregiver, a friend, a co-worker. It doesn't matter if you're a researcher, a doctor, a patient. We all have pieces we can bring to add to what is going on so we can move on in the quest to find a cure for lupus. Yesterday, one more thing, I came across an article. It wasn't sent to me, but I just saw it. And I started reading the article, and I was so intrigued by it. I thought it was fiction. But then halfway through the article, there was a picture, and it was my picture. And apparently, it was an article my niece was writing. And she very cleverly says, this is my lupus story. And then she ends it by saying, I don't have lupus, but I have a lupus story. This is my connection with lupus, my aunt. The lady I learned about, whose husband was talking about her dying from lupus. I have a part to play. Do you? What is your lupus story? So I'm asking you to take that piece today from here and begin to think of what is your lupus story and what is my part to play as we move on in this quest to find a cure for lupus. Thank you. Next.
Thank you very much, Mrs. Nosamefen, for that rousing and moving opening. I will now move on to Dr. Aisha Akinkugbe. Dr. Aisha is a co-founder of the Laba Laba Foundation and is a consultant dermatologist. She graduated from the University of Jos in 1986 and completed her dermatology training at the Lagos University Teaching Hospital. She's a member of the Dermatology Society of Lagos and the International Society of Dermatology. As a dermatologist, she has come in direct contact and has first-hand experience of many patients with lupus. And in seeing them, she empathized with their pain and their anxiety concerning the devastating effects on their skin that the disease was causing. And it was that, that brought her into contact and in touch with Mrs. Chisa Nosamefen, and together they started the Laba Laba Foundation. So we would love to hear a few words from Dr. Aisha as well on the journey of the foundation to date. Dr. Aisha.
Hello, everybody. Can you hear me?
Yes, we can hear you. Go ahead, Dr. Aisha.
Okay. Can I have the slides, please? Good afternoon, everyone in different parts of the world. You're welcome to this symposium. So I'm just going to briefly tell you about the Laba Laba Foundation, our mission and our vision. The vision is that we see a Nigeria where everyone is informed about lupus and where lupus patients can aspire to long and productive lives until a cure is found. And the mission is that we are committed to improving the quality of life of all persons affected by lupus through programs of education, increasing advocacy, awareness, and support that will engage the healthcare community and the society at large. At Laba Laba, we have done various events. We've done a lot of education, awareness amongst healthcare professionals. We've also increased awareness amongst the general public. We have done several radio, TV programs as well. Could I have the next slide, please? There are various activities which we have embarked upon. The Erase Lupus Awareness Program, which is educating healthcare professionals. We offer free counseling to individuals and families through our partnership with the counseling unit of Relate Africa, who have magnanimously offered their services pro bono. We also have the Living Well with Lupus series, whereby we have the lupus patients get together and talk about various things, nutrition, adherence to medication, just various everyday living problems that they have that we can address as a group and offer support and gain more awareness about the problems that they are coming with. We've also had the Frank Talk, and this was headed by Dr. Nusamefa, and it was for men, particularly husbands and fathers, who are connected to lupus patients, either their wives or their children. And that has been very successful, giving the men an opportunity to talk and just let out and understand and share their feelings in different areas. We also have the Pillbox program. We have the Think Lupus campaign awareness. The Pillbox program is a program whereby we offer support in terms of those who cannot get their drugs. We have supporters who give each month a certain amount which could cover. It's just a contribution, but it could cover the amount of drugs they have and their tests. And we've also helped out with hospital admissions. We also have, as Chisa has spoken about, the Odelia Academic Annual Scholarship for Pediatric SLE. And Somto is the current recipient, who unfortunately we lost a few months ago. Next slide, please. So this is these are just pictures showing the activities we have had. Next, please. Two years ago, we started on this journey, and we were able to have we were able to mark World Lupus Day in collaboration with dermatologists, rheumatologists, the Nigerian Society of Rheumatology, Professor Adelowa and his team, other rheumatologists, people at LASUF and LUF, and more importantly, the patients, their families, and their supporters. We also invited resident doctors, medical students, nurses, some secondary school students, and it was open to the general public. And as Dr. Toke has mentioned earlier, this year, unfortunately, COVID has brought us to celebrating World Health Lupus Day in a lovely way, because we can connect with everyone all over the world, and we're doing it via Zoom. So we're thankful in a different way for this opportunity. Next, please. Next slide. Okay, these are just pictures. This was the first recipient on the right, and Somto on the left. Next, please. Next slide, please. Okay, just more pictures at the radio event, at the Frank Talk with Men. These are some of the activities that we have come up. We have loads and loads of pictures there on our website as well, which you can check out. Thank you. Next slide, please. We've also done radio programs with Doctors on Air. We had a session at the West African Rheumatology Conference where we talked about the foundation and just sharing it with other doctors, particularly the rheumatologists. Next slide, please. So the Pillbox program, we've had 70 prescriptions which we've honored. We've done lab tests for 5 individuals, and we've covered 4 hospitalizations and surgeries. The goal is to keep lupus patients on their medication and to keep them stable. For the Living Well with Lupus series, we've had seminars, workshops, and activities, some of the pictures of which you've seen. Had several support group meetings, and it's just an opportunity to learn more about it and coping mechanisms, healthy lifestyles, and debunking, more importantly, the myths and providing the truth about lupus. Next slide, please. In the Lupus Awareness Month, which is October, we've also gone ahead with our awareness activities. As I said, radio programs, TV, the print media, Doctors on Air program. We've also been at the Association of the General and Private Practitioners meetings as well. And then we've had a session with the students at their annual symposium at the College of Medicine 2 years ago. Next slide, please. There is still so much more to do. How can you help? Reach out to us. Support a pillbox program. It's not too much. After listening to the stories and testimonies of various individuals that Ms. Shisa has spoken about, there is a little bit of the puzzle that you can do, and we're reaching out in this medium. We'd like you to volunteer. You could become a lupus educator. You could also become a lupus advocate. Just join us on this walk, because everyone with lupus needs support in some way or the other. Next slide, please. We should have a slide with our details, so we'd like you to just reach out. Thank you for joining in, and we hope you enjoy the Health Symposium. Thank you very much.
Thank you, Dr. Aisha, for that, for sharing with us the journey of the Laba Laba Foundation thus far. Okay, now we will be moving on directly to our first speaker, and I will be introducing her, Professor Adebola Olayinka, and she will be speaking next on the situation of COVID-19 here in Nigeria. Dr. Olayinka is an expert in infectious hazard management and supports the Nigeria Center for Disease Control in the coordination of Lassa fever research. She's currently engaged by the World Health Organization as a research officer and an expert in infection prevention and control. And prior to this, she served as a consultant and a senior technical advisor to the Nigeria CDC on strengthening lab support for surveillance and outbreak management. Dr. Olayinka is a professor of medical microbiology at the Ahmadu Bello University and affiliated teaching hospital. She trained in medicine at the University of Ilorin, has a master's in public health, and is a specialist in clinical microbiology. Ladies and gentlemen, please welcome with me Dr. Adebola Olayinka.
Good afternoon. May I have my slides, please? Okay, so I'll be giving us an update on coronavirus in Nigeria, and then there'll be some information, and then we'll have a look at the national guidelines, and we'll relate this a bit to lupus at the end of it all. Next slide. Okay, so these are the current statistics. As of 30th of May, we had a total of 9,302 cases. That's the cumulative. 2,697 had been discharged, and deaths were 261. We've tested close to 60,000 samples so far, and there are cases across 35 states of the country and the Federal Capital Territory. Now, in terms of mortality, the mortality in Nigeria overall is 2.8%, but this varies from 1.1 to 14.3%. 1.1% for Lagos, 14.3% for Yobe. The recovery has been 29% so far. People who get infected, the most affected age is 31 to 50 years, and it's a male to female ratio of 2:1. Deaths are more common among those who are 60 years old. They actually form 34% of the total of those who have died. And close to 50% of those who have died, the death has actually taken place at home, not in the healthcare facilities. Next, please. So this chart is just to give us an overview of the total number of cases we have according to states. The top bar is Lagos. The next is next slide. And this is to show a graphical representation of how many cases we have on a daily basis. And you can see that the graph is gradually climbing up. Next slide. So let's look at our national interventions. What are the interventions that the federal government has put in place to control COVID? So the first is the ability to detect and confirm cases. And this started with following up passengers of interest. Those are people who travel in and have symptoms, testing them, testing those who are contacts of confirmed cases, testing anyone who is a suspected case, tracing and managing contacts, and then there have been hotlines set up so that people can inquire more about the disease. The second intervention is managing those who are positive, and they're meant to be managed in designated treatment centers. And then we have what we call medical countermeasures that have to do with testing, treatment, and working towards prevention. Next slide, please. We also have social distancing measures that have been put in place. These include the supervised quarantine of travelers, especially the travelers coming back into the country presently, school closures, ban of mass gatherings, restriction of movements, either at the national level or at state levels, what we call lockdown or curfews in some states, and then the ban on international and local flights and restrictions at ground crossings. These are all interventions meant to limit the spread of the disease. The next is regularly communicating on various prevention strategies. There are hotlines available where people can ask questions, addressing rumors, and also a lot of engagement with media have been done to control the epidemic. Next slide. Next slide, please. So what are some of the challenges we have had with these interventions? The lockdown, which is really a mandatory quarantine of households, has been problematic because there hasn't been adequate palliative measures given to those households. As we all know, a lot of Nigerians feed on a daily basis for the next day. So when people are locked down, they're not able to make money, they're not able to feed. We also, this has also led to unrest, violence. There have been challenges with testing and isolation. Vulnerable populations, people with chronic medical conditions are unable to have the medical attention they need. And then there's been a lot of misinformation, rumors, and declining trust in government. Next slide. Next slide. Then there are a lot of guidelines available, and these guidelines span across a lot of areas. They span across surveillance, clinical management, regarding how communities respond, prevention for returnees, businesses, parenting guides, and schools. And these guidelines are available on the NCDC COVID website. Next slide, please. I'd actually want to talk a bit about clinical management. And the clinical management guideline of Nigeria actually does not list chloroquine as a means of treating COVID. But many people are using hydroxychloroquine and chloroquine probably based on reports from other parts of the country. And so the clinical guideline really talks about managing symptoms in mild and moderate cases. For severe symptoms, it's still a symptomatic treatment, but then you may want to add antiviral or antibiotics as the case might be. Next slide. But some clinicians have repurposed drugs like hydroxychloroquine and chloroquine for the management of COVID. And there's been a lot of issues and challenges around this. And some of these are the potential for abuse and misuse by many people. We knew that recently at the beginning of the epidemic, we were actually having people with chloroquine toxicity in some parts of the country. It has also led to decreased availability of these drugs for people who really need it, like people with lupus. It's also led to an increased cost of these drugs. There's also the potential for counterfeiting of these drugs. And this could lead to increased morbidity and mortality for those who need it but do not have access to it. For those who are using it wrongly, there could be adverse reactions. And this has brought to fore the need for randomized controlled trials to actually know what drugs are needed for treatment of COVID. And there are some papers out and there have been a lot of reactions, but there's need for objectivity among the scientific community rather than subjectivity. Next slide. Next. Okay, thank you.
Thank you, Professor Olayinka. Thank you very much for that comprehensive update. There are a couple of questions that have come in with regards to our COVID-19 situation. Someone is asking that, what do you think is the reason why the death rate is so high in Yobe? That could it be a function of the lower testing rate? Therefore, maybe you're not picking up all the people who actually have the infection, so that the mortality rate is actually more accurate. What do you think?
Yobe is one of the states without a testing lab in the state. That is one. Number two, the northeastern part of the country is a hard-to-reach terrain. So you have people who are living in hard-to-reach areas, and by the time they come to the healthcare facilities, they're actually in the advanced stage of this disease. So it's a bit difficult for them to recover. So these are some of the reasons we found out for the high mortality rate in Yobe.
Okay, thank you very much for that. Somebody else is asking whether you have had a lupus patient with COVID-19. To the best of your knowledge.
Well, I'm not aware of that, but it's not impossible. I'm not aware of that.
All right. And I think finally, so what is the NCDC's position on the use of chloroquine or hydroxychloroquine, especially as you've mentioned, it being such an important drug for other patients, such as patients with lupus? What is the current stand? Do we use or do we not use?
Well, the NCDC guidelines currently still do not say use hydroxychloroquine.
Okay.
The organization is conducting a solidarity trial, and hydroxychloroquine is one of the arms. There was a paper recently, that talked about hydroxychloroquine of COVID. But what the World Health Organization currently is doing is analyzing the data they have collected so far from the solidarity trial, and then we'll be informed about the next steps. A lot of the NCDC guidelines are actually based on the WHO guidelines. So at this point, we are waiting for the WHO report of their interim analysis.
Okay, one or two more questions coming in, and I think we just have maybe a minute with you, Professor Olayinka. So I will take one of the questions. Someone is asking if lupus patients have the same coronavirus symptoms as everyone else.
The initial symptoms would be the same as everyone else, but how the disease progresses is what we are not so sure of. Because for people who have underlying and chronic conditions, they tend to do less better than those without. But the initial symptoms would be the same. It's the progression that might be different.
Okay, all right. And one last question about the your COVID status. If you have tested positive and then test negative, how often should they test to be sure that they are safe? I think what the person is asking is about is their antibodies and how long does that last, and is it forever?
Okay, for now, you all know that COVID is still a new disease and we are learning so much about it newly. But the evidence we have for now is once you test negative, you are protected for some time. Now, for how long is what we don't know. So you really don't need testing. You're negative. Hopefully you are protected till at least the end of the year, but there are studies currently ongoing, and these are more from China, who were the initial people that started the disease, to know how long those antibodies are protective for.
Thank you very much, Professor Olayinka. And I think it's great that we are also doing our studies, because it's important for us to know how the disease pattern in our environment as well. So hopefully as time goes on, we will also have more information on how to manage it in Nigeria. Thank you so much, Professor Olayinka. Now, I will be moving on to our next speaker, Professor Asghar Kalla, and he will be speaking to us about lupus in Africa and the hope for the future. Professor Kala graduated from the University of Cape Town in 1975 and obtained his specialist physician qualification, the FCPSA, in 1979. He obtained the Doctor of Medicine MD degree in 1989 and the Fellowship of the American College of Rheumatology in 1992. He became an Associate Professor of Medicine in 1997, an Isaac Albo Professor of Rheumatology and a Fellow of the Royal College of Physicians in 2001, and is an Emeritus Professor at the University of Cape Town since 2017. Professor Kala is the past President of South Africa Rheumatism and Arthritis Association and is the current President of the African League of Associations for Rheumatology, AFLA. His research interests include osteoporosis, disease activity and disability assessment in rheumatoid arthritis, and also in other rheumatic diseases, including SLE. Please, ladies and gentlemen, welcome with me Professor Asghar Ali Kala. Professor Kala.
Thank you very much for those kind introductory words. Can you hear me?
We can hear you, Professor Kala, loud and clear. Thank you.
I'm indeed honored and privileged to be part of this very austere group of members. And I'm delighted to be involved in this discussion on SLE in Africa. Thank you very much for inviting me. Are we going to go on to the slides? So, as you know, we're going to be talking about systemic lupus erythematosus in Africa. And in the next 10 minutes or so, I'm going to try and give us a picture of where we are and where we hope to be in the future. Next slide, please. So SLE, as we know, is an inflammatory multi-system disease of unknown cause with diverse clinical and laboratory manifestations and a variable cause and prognosis over time. And as you've heard, many patients can die from SLE. Next slide. The difficulty that we have about SLE is that the cause is unknown. Many postulates have been put forward. In about 10% of patients, we have identified genetic factors, and these are mainly from twin studies. A number of viruses have been incriminated, but there is no solid data to support their involvement in the process. Hormones are definitely likely to be involved, especially if you look at the predominance of the disease in females, suggesting that estrogen may be important. And we do know that sunlight can induce flares and particularly affect the skin in lupus. There are also a number of drugs that may induce a lupus-like syndrome. Next slide. So when we look at the actual pathogenesis of SLE, and if we use ultraviolet light as an example, essentially what is happening is that it causes the keratinocytes to become damaged. And because lupus patients are unable to process normal cell death because they have defective apoptosis, the result is a number of apoptotic cells. And as you'll see on the slide, these cells have large blebs as well as small blebs. And the autoantibodies that are produced in lupus are mainly from the large blebs. Now, these blebs contain massive amounts of nuclear and cytoplasmic material, and they serve a very prominent nidus for autoantibody production. Next slide. So a number of useful autoantibody tests are available in SLE. The first of these and the most common of these is the anti-nuclear factor, or also known as the anti-nuclear antibody. Then we have the anti-double-stranded DNA antibody, which is very specific for SLE. A number of different extractable nuclear antigens, which are also found in lupus, and a very important pathogenic or pathological antibody called the antiphospholipid antibody, also known as the anticardiolipin antibody. The difficulty is that not all of these antibodies are easily available within African countries, particularly antibodies like the anti-double-stranded DNA antibody. Next slide. So it is for this reason that the classification criteria that are often used in making a diagnosis of lupus are very heavily weighted towards the immunologic criteria, as you'll see from the SLIC criteria that were published in 2012. Not only are there immunologic criteria, but also a number of clinical criteria. And if you look at the clinical criteria, you'll see the multi-system nature of SLE. And SLE can certainly affect the kidneys, the brain, as well as all the other organs within the body. So that to make a diagnosis of lupus, or rather to study patients with lupus, you need at least 4 criteria, of which at least 1 should be clinical and 1 should be laboratory-based. Next slide. So the commonest clinical feature is the butterfly rash. Next slide. Next slide. The presence of alopecia, which can be quite disfiguring. Next slide. The presence of a more diffuse rash, sometimes referred to as subacute cutaneous lupus erythematosus. And this is in a young female at the age of 17. Next slide. And this is an elderly female who has developed lupus. So lupus is not only a disease of young females, and it can occur sometimes in older females, especially when they are using hormone replacement therapy. Next slide. So when we look at epidemiological studies, many of the studies are old, and one of the studies done in the 1980s in South Africa showed that in Cape Town, the prevalence of lupus was approximately 50 per 100,000 cases, and this is considerably higher than the prevalence reported in Northern Hemisphere, such as the UK and Sweden. The disease was most common in females in their reproductive years between the ages of 16 and 45, and the female to male ratio, as is to be expected, was 9:1. Next slide. Now, this is a study that was reported very recently. In fact, it's virtually hot off the press because it was published in March or April this year. And this is a very good systematic review looking at SLE in native sub-Saharan Africans. There's just a few points that I would like to draw to your attention from this article. The first of these is that they reviewed about 1,500 papers and could only find 15 papers that were adequate for the analysis that they were undertaking. They managed to work out a incidence of lupus, but the conclusion that they came to was that there is a lot of data that is still outstanding and that needs to be done for us to understand lupus better within Africa. Next slide. The 15 papers that were used for the study, 10 of them were from West Africa, 2 of them from South Africa, and 3 of them from Central Africa. And if you look at this map of Africa, you'll see the dearth of information from many of the other countries in and around Africa. Next slide. This is another study that I'd like to bring to your attention. It's called the ALUGEN study, which was initiated at the University of Cape Town. And the idea of the study is to develop a registry of lupus patients around Africa. Now, the advantage of having such a registry would be that we could develop a data set and a cohort of patients within Africa who have lupus, and this could serve as a basis for biological and other studies within Africa. And we are encouraging members around Africa who are interested in lupus and who have lupus patients to contribute to this registry. Next slide. So if we summarize the features of lupus in Africa, the pooled index or the pooled incidence, according to the systematic review that was done, looked at 28,575 patients and found an incidence of 1.7%. The age at onset was between 28.8 and 39.2 years, and skin, joint, and hematological involvement was extremely common. The difficulty is that there was a wide range of prevalence of these symptoms and signs in the studies that were looked at. 99% of the patients were treated with prednisone, and about 2/3 were treated with chloroquine. Some of the patients had severe disease, as characterized by kidney involvement and brain involvement, and the biggest contributor to mortality was the presence of infection. In fact, in this particular systematic review, they found a very high pooled mortality of 10.3% per annum. Next slide. Now, one of the other issues that we are faced with as rheumatologists in the context of Africa is the coexistence between systemic lupus and HIV. And a number of studies have been reported in the literature drawing this coexistence to mind. However, it would seem that the association is probably less than would be expected from the broad incidence of HIV itself. Within South Africa, there have been only a few case reports, and these have come from Johannesburg and Durban, and I have no doubt that there are many similar case reports in other parts of Africa. Next slide. So when a lupus patient presents to us in hospital, usually a very sick lupus patient, the difficulty that we have is in differentiating between a flare of the lupus and the presence of infection, because if there's an infection, we may need to reduce the lupus therapy, whereas if it's a flare of the lupus, then we may need to increase immunosuppressive therapy. So it's a very delicate balance that we sometimes need to follow in the clinical contexts. There are a number of things that we use to assist us in differentiating between infection and a flare, but none of these are 100% sensitive or 100% specific. Next slide. With respect to the treatment for lupus, in Africa, we are fortunate that we have all the treatments that are currently available worldwide, and you have heard mention of the use of chloroquine. Chloroquine, in fact, is a very good form of treatment for SLE, and there are some researchers who believe that SLE, in fact, all patients with lupus should be on chloroquine. Prednisone is very effective, but unfortunately does have side effects, and cyclophosphamide and MMF are usually reserved for patients with lupus nephritis. Rituximab is one of the newer biologicals and is probably very useful in the context of Africa. Next slide. Next slide. We can pass over the slide. So in terms of what we hope to see in the future with respect to Africa, I think we need to see more clinical and lab research from Africa. We need more epidemiological data. We need earlier referral to specialist rheumatologists. We need access to dialysis and intensive care units. We also need to provide special assistance with antibody. Thank you very much for your attention.
Thank you very much, Professor Kala. Thank you very much. Let's see if anyone has any questions for question and answers in the question tab. So please send in any questions that you might have for Professor Kala. Thank you. Okay, so we currently don't have any questions, Professor Kala, so I might come back to you if any questions come in for you. Okay, one question has just come in And someone is asking, can a patient on prednisolone be taken off and moved to chloroquine?
The answer is probably yes, although they work separately. And most rheumatologists believe that if chloroquine is working well, then you often do not need prednisolone.
Okay. Thank you very much. I think that answers the question for the lady. Another question is asking that what is your experience with cardiovascular complications in Africa? Lupus patients.
From chloroquine or from SLE?
No, I believe the attendee does not specify, but I want to believe it's from chloroquine, given the
Controversy
that come out. Yes.
In clinical context within the use in SLE, we haven't really encountered cardiovascular complications, and it may be the dose that we are using.
Okay, so the attendee has now specified that he or she from SLE. So what is your experience with cardiovascular complications in SLE patients in Africa?
Okay, so if complications are relatively common, if you divide the vascular complications, you've got to think about the pericardium, cardium, for the valve, and the valve within the them all. A lot of about mortality, the vascular complications, because as the patients grow older with their lupus inflammation. Cardiovascular complications in general probably occur in about 20% of patients with lupus.
Okay, and I will only be a lot of questions coming in now, but I will only be able to take one more, and then perhaps we might be able to answer some of the other questions at the end of the session. And someone has asked, what alternative treatment is there for discoid lupus as chloroquine leaves her skin gray? She's asking for alternatives.
Okay, that's a very good question. And you know, usually this complication of chloroquine occurs when there's a lot of exposure to sunlight. The other alternatives would be drugs like azathioprine, but maybe one of the dermatologists on the panelists might want to address this at a later stage in the session.
Okay, so perhaps we'll come back to that again when we're taking questions at the end. Thank you very much, Professor Kala. Thank you. All right,
Pleasure
now
for having me.
I will be moving on to the next speaker, Professor Olufemi Adelowo. And he will be speaking to us about the evolution of lupus medicine and management in Nigeria. Professor Adelowo is a professor of medicine and is a consultant rheumatologist, graduating from the University of Ibadan College of Medicine in 1973. Professor Adelowo was the first Nigerian and West African to train in rheumatology and is a fellow of the West African College of Physicians, the Royal College of Physicians in Edinburgh, and the Royal College of Physicians in London, and is also a master of the American College of Rheumatology. Now, he has established during his long and illustrious career, he has established the rheumatology clinics in many teaching hospitals in Nigeria, and has thereby trained over 50 rheumatologists who are now consultants in different teaching hospitals. Ladies and gentlemen, please welcome with me Professor Olufemi Adelowo. Professor Femi.
Thank you very much, Dr. Oke, for inviting me, and more especially to Chisa for inviting me to this Lupus Awareness Month. We have been in collaboration with the Labalaba Foundation for over 3 years now, and we have cooperated quite some, in terms of spreading what we need to know about SLE. To talk on the evolution of lupus medicine and management in Nigeria. Let me make some 4 or so statements. One is that there was a supposed rarity of lupus based on a gradient theory that said lupus was rare, sub-Saharan, and then as you go to North Africa, that and beyond, then the lupus continues to incidence continues to rise. We know this is not true. There was also another publication that links the rarity of autoimmune disease with presence of malaria fever. That the more of malaria fever you have in any society, the community, the less of autoimmune disease we have. We know this also may not be true. Now, lupus is that chameleonic, what I call chameleonic disease, because it changes color. Then it's also hydra-headed, and for those of us who did elementary biology, we know that if you cut off one arm of the hydra, another one grows, and that's exactly the way lupus behaves. Then finally, let me state that the lupus, for some reason, and I'm sure those who have had to deal with lupus in Nigeria would confirm this, for some reason seems to affect the beautiful women. Most of our lupus patients are beautiful. And each time I'm running my clinic and somebody asks, how does a lupus patient look? And I said, come to my clinic. If you see any beautiful girl there, that's more likely to be lupus. Then I'm to talk on the evolution of SLE. That parallels very much with the evolution or development of rheumatology. So most of the things I will say earlier on will be about the evolution or the development of rheumatology in Nigeria. Next slide, please. Next slide. Next slide. Next slide. Okay, now there was country lupus reports from Nigeria before 1975, and probably the first one was the one by Greenwood in 1975. Then in 1982, we reported a few. And in 1994, there were 3 case reports from a private clinic, that was Eco Hospital. Community studies, lupus has not been recorded in the 2 major community studies we have had. One was in the northern parts of, around the Jos area. There was no SLE out of the 2,454 subjects that were seen. Then we did one in Agbowa, which is near Ikorodu, and we saw 3,828 subjects, and there was no lupus in any of them. Next, please. Next slide. Now, in terms of the clinics, how has rheumatology clinics evolved, which will parallel also the identification and the publication on lupus. The earliest lupus or rheumatology clinic was in 1979 to 1982 at UC Chipadon. Thereafter, there was one 1983 to 1985. Olabisi Onabanjo Teaching Hospital 1992 to date. Lassuth and Luth, variously 2012 and 2015 to date. And presently, because of the increasing number of rheumatologists who can identify and manage lupus, we have rheumatology clinics scattered over every zone of Nigeria. And that means that presently, like I would say, there's a rheumatologist about 100 kilometers away from you. There are future clinics going to come up in Yenogwa, in Calabar, Port Harcourt, and Katsina. Next, please. Next slide. Next slide, please. Okay, now let's look at the rheumatology manpower. Before 1982, there was no clinical rheumatologist. From 1982 to 2007, we had only 1 rheumatologist. But since then, thereabouts, we've had about 47 rheumatologists, like I said, scattered all over the country. Do you have any pediatric rheumatologists? There's actually 1 in training now. And that would be the first pediatric rheumatologist in Nigeria. Next, please. Next slide. Now, laboratory-wise, most of the diagnoses then were made using what they call early cell, which was quite imprecise. So pre-2005, there was no immunology or serology laboratory. And like my colleague Asgar said, you need serology to make a diagnosis. Before then, I mean, pre-2005, samples were actually sent to UK for the serology. There was the doctor's laboratory in London, where we'll send sample and may take about 2 months before we get the results. Thank God for the Pathcare Laboratory, which was the first to come into the country, and that has really, really helped the development of rheumatology and the diagnosis and management in Nigeria. Treatment, either though, had been with antimalarials, especially hydroxychloroquine is what we use in Nigeria, azathioprine, mycophenolate mofetil, cyclophosphamide, which could either be what we call the Lupus regime, which is a low-dose cyclophosphamide, as distinct from the NIH Mayo Clinic regime, which is rather high dose. And because our young women are particular about their fertility, we prefer to use the low-dose cyclophosphamide, the Lupus regime, rather than the NIH. But in certain situations, when, for instance, we have a rapidly progressive lupus nephritis, we tend to use the NIH, which is the high dose. But of course, we explain to the patient and let the patient know that we are doing this because we want to conserve life or conserve organ. Right from the word go in our management of patients with lupus, we take it for granted, and we know that all young women would want to get married, want to have children. And therefore, most of the time, we start them with drugs that we know are compatible with pregnancy. Drugs like hydroxychloroquine, azathioprine, tacrolimus, those are the ones we normally will use routinely. We tend to avoid the mycophenolate mofetil, the cyclophosphamide, because of their teratogenic effects. So most of the time, hydroxychloroquine, azathioprine are what we use. We even avoid methotrexate too because of its effect on pregnancy. Next slide, please. Next slide. Now, do we really have reports on the different aspects of lupus? And the answer is yes. First of all, probably one of the largest series that brought lupus out in terms of sub-Saharan Africa was the report in 2009, a report on 66 lupus patients from a private clinic. And that had been like the forerunner of other publications that have come in terms of Black Africans. Then we've also had a report on neuropsychiatric lupus, and we know that most of our patients had things like seizures, like cognitive impairment, like depression. These are the common things that we see in our patients. Then serology, just like elsewhere, antinuclear antibody is what we use mainly, and we see in about 95% of all cases. And that makes it more sensitive to use than early cell, which is just about 40% sensitive. We also have a fairly high anti-double-stranded DNA at 50-something%. And then we have the anti-Smith, which is commonly seen in Blacks. We also see the anti-RMP, ribonucleoprotein, which is also commonly seen in Blacks. Renal presentation, many of our patients, right from the presentation, come in with renal involvement, about 1/3 of our patients. And therefore, when we manage our patients, it's always a race against time to prevent that the kidneys are not involved. We've had reports, and we've seen over and over again, patients, young girls who come in with renal pathology. And then we work backwards and find out that what they have is lupus. They have no other features, they have no other symptoms apart from a renal presentation. So it is now standard for us in both Luth and Lasso, that anytime we see any young patient with any renal pathology, we must investigate for lupus. Juvenile lupus has been uncommonly reported, and this we have reported in Nigeria. And then neonatal lupus. Neonatal lupus is also rare, but we've had a patient with a lupus patient giving birth to a neonatal lupus. We also had another lupus patient giving birth to a patient with congenital heart block. The baby had congenital heart block. Next, please. Now, let's look at, is this really so rare? Now, let me just look at an audit of 4,000 patients we are seeing in private clinic, ultimate specialist clinic. And out of the 4,000, just to put it in perspective, osteoarthritis, which is the commonest condition that we see in rheumatology clinic, considered 49.2%. Rheumatoid arthritis, another autoimmune disease, constitutes about 11.6%. Systemic lupus erythematosus, SLE, we saw in 213 patients, which constituted 5.3%. And this is the same trend we see in the other clinics nationwide. Next, please. Next, please. That's a picture of a patient with malar rash. We don't see malar rash commonly among our patients in Nigeria, but the occasional one we see, the whole picture has been obfuscated, because of some astringent that they apply. Next, please. What are the challenges with the diagnosis and management? I think the major one is the poor understanding of the clinical presentation of patients and clinical presentation by patients and doctors alike. Most of our patients come in with this malaria, typhoid, and that goes on and on for months and weeks. Then you begin to see the patient wasting away, getting fatigued. They may or may not have any rashes. As a matter of fact, most of our patients have no rashes. They are what I would call fine skin, no pimple, no skin at all. But they do have mouth sores. They do have alopecia because of the loss of hair. They have fatigue. They lose a lot of weight. Then there's also the misconception that it is a spiritual attack. Every patient that I see that has lupus tells me it is a spiritual attack. And because of this, valuable time is lost before they get to see a rheumatologist. So there is a delay in presentation to rheumatologists because of all these factors. Another challenge is the lack of reliable laboratories for serology. Many of the reports we see may not be that reliable. Okay, I have 2 minutes more. Then the final one is non-availability or non-affordability of medications. Now, next slide, please, which will be the last slide. What are the challenges to patients? And this I will put in terms of questions. What questions do our patients ask us? One, because they are young girls. One, will any man marry me? And I think it's quite troubling for many of the patients. Second, will I spread lupus to others? For instance, if I get married and I've had a potential husband coming in and asking me, would it spread to me? The third is, will I even get pregnant? The fourth is, even if I get pregnant, can I carry the pregnancy to term? And then some patients will ask me, would this lupus, would it kill me? Then what happens if I don't take my drugs? We know that after some time, patients get tired of taking drugs day in, day out. They do get tired and they ask me, what happens if I don't take my drugs? And then even if I get pregnant and have a baby, would my child have lupus? And should I take my medications when I become pregnant? These are the questions that our patients would ask us, and we'll have to find time to explain to them. This essentially is the last slide, but the next few slides are the pictures of patients with lupus. Can you please quickly go through them? Next slide, please. Yeah, there's a patient. This is sometimes type of rashes, quite disfiguring and embarrassing to the patients. Next, please. Next slide. Again, there's a patient with malar rash, which many times in our patients crosses the bridge of the nose. Next. And these are some of the rashes that the patients have to contend with. Now, these are sometimes not so pleasant looking rashes. For many of them, when they are subacute, we can actually use drugs like dapsone and thalidomide. And this, by far and large, what we see. These are the references. Thank you very much for listening, and thank you to the Labalaba Foundation.
Thank you very, very much, Professor Adilowo. Thank you. I think I will ask you to answer some of those questions that you posed at the end. I think they are very important. And many people have actually already asked whether lupus is contagious. Is it hereditary? So perhaps if you go ahead and answer that, because we have had many attendees asking.
Well, in terms of being hereditary, there is that tends to be what's called a familial clustering of lupus. That is, if a mother has it, it may be in that generation or generation after. But even then, that is not invariable. That does not mean that every person who has lupus, the child or the grandchild or the cousin, may have it. I think the hereditary aspect is probably less than 10% of the lupus patients that we see.
Okay, and in the hereditary cases, how soon in life can you test for possible genetically acquired SLE?
Well, I think sometimes our patients come to us and ask us to test their daughter. If the serology tests are positive, that's especially in high titers, and especially certain serology like anti-SM or high titers of ANA, the chances that that child may develop lupus is high. But we cannot start treatment except there are symptoms. And there's quite a lot of controversy about this. Should we or should we not start treatment? I think the only time one wants to start the treatment is when there's obvious evidence of clinical manifestation. Of course, that requires monitoring the patient or the child or the daughter or whatever it is on a regular basis.
Okay, thank you for that answer. I have a couple more questions for you, Professor Adilowo. A colleague is asking what you feel is the major research priority for lupus in Africa.
Well, I think one major priority would be the genetics of lupus. That should be one of the agenda, the genetics of it. And I dare say that presently we are collaborating with another speaker on this forum, Dr. Blazer, on the difference in the genetic presentation between Nigerians and Black Americans. We know that lupus has a high presentation among Black Americans. Our genetic manifestation, genetic constitution, are they the same? This one area that we're looking at. Another area would be the issue of therapeutics. The drugs we use, can we use less of the immunosuppressives, or do you have to use more? And that's one agenda we can also look at. Those two are
research into, yes. Okay, what about, you mentioned the question about about fertility and young women, as seen as many of your, many SLE patients are young and female.
Yes, that's right. Yeah.
What is really the outlook for getting pregnant, on their fertility? What would we be saying to encourage young women who have SLE?
But the fact is that, and this is based on studies, that there is no decrease in fertility for lupus patients. What may be different is that being able to carry the pregnancy to term. And for that, there are so many factors involved. One could be in terms of the management of the patient. If the patient is in remission before she gets pregnant, chances of carrying the pregnancy to term is good. If the patient does not develop certain antibodies, which we usually monitor in patients, antibodies like antiphospholipid antibodies, which can predict pregnancy losses. So if those two are okay, and if they take their drugs, because it's one thing to get patients to take their drugs. Sometimes when they get pregnant, and I know the mindset of gynecologists. The gynecologists do not want them to take any drug at all. But that's the mindset, that's the way they're trained. But we tell them that if you don't take your drugs, especially the ones that are compatible with pregnancy, chances of carrying that pregnancy to term is virtually zero. So we got to choose that. We got to manage you with some of these drugs, and therefore, don't stop your drugs. Let your rheumatologist advise you on what to take. We may increase or decrease depending on the situation.
Okay, so it's a very delicate balance. Everybody has to work together. It has to be a multidisciplinary team looking after pregnant women with SLE.
That's correct. That's correct.
Final question for you, Professor Adelowo, before I let you go. A couple of people have asked that what is the outlook for young doctors specializing in rheumatology? As in, what can we do to train more doctors? And if you could just give us 10, 15 seconds on, about that. Thank you, sir.
Well, presently, there's only one training ground in any training center in Nigeria. That's in Lasso. But we've been able to combine that with clinics in Lupus. So they have actually 2 teaching hospitals they're supposed to. And because I handle rheumatoid cases in both centers, we're able to train them. Now, in terms of their training, they have to go through the fellowship training. Either the fellowship of West African College of Physicians, which is at least a 6-year training program after MBBS, or the National Postgraduate Medical College, FNCP, which is also an equivalent of 6 years training. All our trainings are domiciled in Nigeria now. They don't have to go outside this country. The training is done in Nigeria.
Yes.
Yep.
Thank you so much.
Done in Nigeria.
Thank you so much, Professor Adelowo. Thank you. Okay, so now moving on to our next speaker.
Thank you very much.
We're going to be hearing from someone who is living with lupus herself, and will be sharing with us her experience. Dr. Itegboje holds a master's degree and a PhD in mathematics and computer science, and has over 28 years teaching experience as one of the foremost polytechnic levels in Nigeria. She served as the head of the Management Information System Unit at the Yaba College of Tech for 7 years. She's a research scholar at the International Center for Information Technology Development, and is a past council member of the Computer Professional Registration Council of Nigeria. Is now a retired college lecturer. And she's had a difficult journey with her lupus after being diagnosed with lupus. Dr. Itegboje, we are very happy, we're really honored to have you here with us to share your experience. I'll hand over to you now.
Good afternoon.
Good
evening. Good evening.
Good evening.
Good evening.
We can hear you, ma. Please go ahead.
Good evening. Okay. You want me to share my slide, or you have the slide?
We have the slides, ma.
You want me to share the slide, or you have the slide? Okay, you have the slide. Oh, good. Good evening, everybody. I'm Dr. Itegboje. I'm speaking about lupus from the patient's angle. And my topic is more than a disease, understanding the challenges of living with lupus. Can I have the next slide? What exactly is lupus? From my research, Lupus is defined as a long-term autoimmune disease in which the body's immune system becomes hyperactive and attacks the normal healthy tissues. Naturally, immune systems are supposed to fight infections, but rather than do this disease that is named lupus sees the healthy tissues and organs in the body as invaders and begin to attack them. This is most unfortunate, but one can really not explain it because why that happens, nobody knows. Can I have the next slide, please? Next slide. Next slide, okay. Why would one say lupus is more than a disease? I once read that lupus is described as the cruelest disease in the world. And I guess the reason for this is it meets other ailments, therefore making it difficult to diagnose early. And from my own experience, we heard when Dr. Adelowo was talking, patients are treated for malaria, of course, which I was treated for several times. I was treated for typhoid, even when they would not find the typhoid or the malaria parasite, they will still say we have to treat for typhoid because what you're presenting looks like typhoid or malaria. So I had to go through all that. Then at a time, I started having rashes in my body. And of course, it was outside the country then. It was outside Nigeria. And they kept saying it was allergy. I kept taking allergy vaccine from one allergy vaccine to the other. And then after that, it was having atypia, you know, and I had to undergo hysterectomy. After that, it was something with my lungs, and they had to remove fluid from my lungs. Later on, I came back, they started testing for connective tissues and so on, and they couldn't find anything. And of course, at that time, the sample had to be sent to South Africa. But eventually, in 2014, I came back to Nigeria and went to the skin clinic. And they took a sample of the tissue from my scalp. And it was then I was diagnosed. You can imagine how many years I had suffered before eventually I was diagnosed. A sufferer can wake up feeling very good in the morning, and the next time you are down, and people around you begin to wonder whether you are Abiku. Abiku means somebody that comes and dies and comes and dies and comes and dies. Sufferers grapple with pain and fatigue continually. The disease can affect multiple organs of the body of the sufferer. Inflammation upon inflammation, swellings, damage to the joint, skin, kidneys, blood, heart, and lungs. And so you can understand why lupus is described as the cruelest disease in the world. And that is why it is indeed more than a disease. Next slide, please. Next slide. The challenges from my own perspective, remember I said I'm looking at lupus from the patient angle. What exactly are the challenges from my own perspective? The challenges that a sufferer faces are regular pain and fatigue. You really want to be up and doing, but you cannot. And this is usually looked upon by people around you as that you are lazy, or you just want to fake illness, you know, pseudo illnesses and all that. Dreading hospital visits. I dread going to the hospital because it drains me and I end up being sick. Tired of too many drugs that has no time limit. You have to take hydroxychloroquine, you have to take Sidalud, you have to take so many. You know, you have to take amitriptyline, you know, so many drugs that you have to take. And this drug, they have no limits. They will tell you you have to continue taking it because lupus has no cure. So these are challenges from my own perspective as a lupus sufferer. Costly blood works. You have to do blood works all the time, routine checks up, and medications that are very, very expensive. We used to buy hydroxychloroquine in Nigeria, 20 tablets, for 2,250 naira. That probably comes to like less than $10. But now, the same 20 tablets of hydroxychloroquine, if you're lucky to find it, it's over 22,500, which is close to, that's like about $50. You can imagine, from something that was less than $1 to something that is now about $50, and yet you still have to take it. Next slide, please. Next slide. How can these challenges be minimized by those that are around us? As lupus sufferers, you have certain people that you have to relate with.
Chisa.
The caregivers,
Chisa.
doctors, nurses,
Hey.
other
Chisa.
medical staff in the hospitals, employers of labor, professional colleagues, for those who are in paid employment, your friends and your family members. These are the people that are around you. And so I am going to be discussing around these people that we will call significant people to us that are lupus sufferers. The caregivers, the employers of labor, the professional friends, the family members. How exactly can they assist in minimizing the challenges that I had talked about earlier on? Next slide, please. The caregivers. The caregivers, I am appealing that they should give prompt attention to sufferers whenever we visit the hospitals. And my reasons are this. Lupus flares are triggered by stress, and hospital routines could be very stressful. The nurses will tell you, you have to be in the hospital for 6 a.m. Many sufferers don't have personal transportation of their own. And so they have to take buses, they have to take Okada, that is the motorcycle, as the case may be in Nigeria. And by the time they get to the hospital, they're already drained. And then they still have to wait. Some probably may not see their doctors until maybe around 1 o'clock, 2 o'clock at times. And for some who have multiple doctors to see, maybe they have a skin doctor to see, maybe they have a gynecologist to see, maybe they have the heart doctor to see, you know, so many doctors that they have to see. And at the end of the day, I can understand the plight of the doctors in Nigeria because they are very, very limited. And I really, really appreciate the doctors in Nigeria because they are working really, really hard. But despite that, I'm making an appeal that they should please try to give lupus sufferers prompt attention. Because lupus flares are triggered by stress, and hospital routines, from my own angle, would be really, really stressful. So I, as a person, dread going to hospital visits. Then another reason is that hospitals are places where one can easily contract other diseases. So longer wait time should be avoided. Our immune systems are already compromised. And so the longer we stay in the hospital, the worse it is for us. Next slide, please. The employers. Employers should be accommodated towards sufferers by empathizing with sufferers when they cannot perform to expectation. There is an expectation that is expected of an employee by employers. But for a good employee who has served the employer very well, whenever such employee cannot meet up to expectation, I would expect that employers should be accommodative. They should not look at it that this person is always coming sick, he's sick today, he's not well tomorrow, he's fatigued, and so on. Please, I'm making an appeal that employers of labor should be more accommodative. And where, and if possible, flexible work schedules should be given to lupus sufferers by employers of labor. Next slide. Next slide, please. Professional colleagues. Of course, wherever we work, we have our professional colleagues. And I think every lupus sufferer needs to educate their professional colleagues on what exactly lupus is. There's nothing to hide about it. You did not make it. If it is maybe something like AIDS, you will say it is your making. But this is not your own making. So please educate your professional colleagues so that they can, whenever you cannot perform to expectation, they will be able to relate with that and not look at you as a lazy person. Next slide, please. Next slide, please. Friends should support sufferers by praying for and giving words of encouragement at all times. Regular visits, check up on their well-being, organizing exciting outings that can relax the sufferers. Next slide, please. Next slide. Family members. The best support that family members can give a sufferer is to create an atmosphere that reduces stress to his barest minimum. And because lupus treatment and management consumes a lot of finance, family members should be prepared to support in this area. Next slide. Next slide, please. And in conclusion, this is to lupus sufferers everywhere. Lupus is not a death sentence. So sufferers should do away with pity party or seeking for sympathy. Keep to the rules of reducing flares so that you can have better quality life and trust in God that all will be well. And whenever you are at your best, put your best in whatever you're doing so that anytime you are not in your best, people can understand. Thank you for listening.
Thank you very much, Dr. Otegboje. I think that was very, very helpful for anyone who may be living with lupus. You had very practical advice and practical tips, even for the carers and even for the people looking after them, like the doctors. So thank you so much, Ma, for that. It was also very encouraging. Thank you. We will now be moving on to our next speaker, who is Professor Ashira Blazer. We have Professor Ashira Blazer here with us, and she is an assistant professor at the New York University School of Medicine Division of Rheumatology. And she's studying the biological and genetic determinants of SLE, especially in those with African ancestry, so African and Black Americans. And her current research project focuses on the polymorphisms of the APOL1 gene. As we know, this is a major contributor to excess renal and cardiovascular risk in African patients. Dr. Blazer, I'm going to hand over to you now for your talk. Thank you.
Thank you. And may I share my slides? May I share my screen?
Yes, go on. Yes, you may share your slides. Thank you.
Okay, sure. One moment. Share screen. Oh. It's saying I can't. Maybe, do you have my slides then? It's saying that I'm unable to. Can you, it says that I'm unable to share. You're muted.
Have you been handed the mouse? The slides are for you, so you're in control of your slides.
Oh, I see.
Okay, you're in control of them. Can you see it?
Next. I see. All right. Okay. Okay, great. All right, thank you very much for having me. So I'll be speaking about APOL1 risk alleles and their implications for lupus health in the African diaspora. So, okay, So we know that lupus is a major cause of morbidity and mortality, especially in minority women. And these data are from the United States. And this is looking at the lupus as a top 10 cause of death in all women, ages 15 to 24, 25 to 34, 35 to 44. And what we can see here is that for all women, lupus is actually a top 10 cause of death in the younger generations, but it drops out of the top 10 in the older generations. But when you look at Black American women, you see that it stays in the top 10 even through age 44. So there's clearly a difference in mortality for lupus patients. And while the etiologic framework for this is really complex, we've been studying genetics because we know that a lot of this excess mortality is actually due to kidney disease and cardiovascular disease, which is more common in patients who develop lupus. And so what we've been studying is this ApoL1 or apolipoprotein L1 gene. And so I'm going to, with my drawings, show you a little bit about ApoL1 and why it's so common in people of African ancestry. So ApoL1 is a gene that produces a protein that can be secreted by liver cells. And when that happens, this protein travels around with HDL3 particles. So you've heard of LDL, HDL. These are very dense lipoparticles. And so these will travel around in the blood. And when somebody becomes infected with a trypanosome, so this is my trypanosome, trypanosomes like us like to eat very fatty things. And so they will eat these HDL3 particles. What happens is that this particle goes to the lysosome to be digested by the trypanosome, and the lower pH in the lysosome allows for ApoL1 to pop off and put a hole in the lysosome. And this causes lysis of the trypanosome, or killing of these trypanosomes. So it's actually a part of our immunity to trypanosomiasis. So in areas like West and Central Africa, where Trypanosoma brucei is endemic, native ApoL1 was able to lyse these organisms. However, over time, the organisms mutated so that they could bind the terminal portion of this ApoL1 protein. And so in turn, these mutations arose in this area so that the trypanosome could no longer bind ApoL1, and therefore there's this enhanced killing of trypanosomiasis. So this is why we think that it was evolutionarily selected in these regions. And so what I'm showing here is a map of different West African countries, or just general sub-Saharan African countries. And you can see here in West Africa, so in each of these pie charts, the native unmutated ApoL1 allele is shown in red. So that's the proportion of people carrying native alleles. The G1 allele is shown in blue, and G2 is shown in green. And as you can see in places like Ghana and Nigeria, most of the alleles are these mutated copies of the alleles. So the allelic frequencies are incredibly high. And so this is showing African Americans, where about 20% are G1 alleles, 13% are G2 alleles. And then looking in Nigeria and Ghana, you can see that, in certain Yoruba peoples, 45% of the alleles are G1 alleles, 16% are G2 alleles. So these mutations are incredibly, incredibly common. Now, could lupus plus these ApoL1 variants be the perfect storm? So I say this to say that, as we know, these variants are incredibly common. And thankfully, most people who carry 2 copies of the variants don't actually end up having any disease. We know that there's an interaction between having chronic inflammatory or chronic infectious disease and carrying these variants. And so whereas somebody who's otherwise healthy may have about a 2-fold increased risk of developing chronic kidney disease, given that they carry 2 copies of these variants, someone with lupus has a 5 to 11-fold increased chance, right? And so we're thinking that the reason for that is that the inflammatory pathways of lupus actually increase expression of ApoL1. So, DNA is a blueprint, and so you only need to use a blueprint when you need it. Like if you had a blueprint of a mall, you wouldn't build a mall without needing a mall, right? So when the body becomes inflamed, it needs these proteins such as ApoL1, and so it starts to increase the production of ApoL1 protein. And so you get, in the setting of lupus, the inflammation of lupus driving ApoL1 production, and then an increase of the concentration of that ApoL1 in cells and tissues. And so we wanted to look at people who have lupus and who carry these variants in an African population and what that means for their disease. And so in 2005, this is our team in Ghana. So this is me in 2005 and one of our patients. We built a team, built a study registry, and we were able to collect information over time, so over a year's time point, as well as collect DNA samples and blood samples of these patients. And we had a really good time doing it. Okay, so these are Ghanaian patients recruited from Korle-Bu Teaching Hospital in Accra, Ghana. So we had, at time 0, we collected patients who were of self-reported African ancestry for lupus criteria, and patients who were unable to sign consent or had insufficient African ancestry were excluded. And we followed them at month 0, 6, and 12 at their usual clinic visits, got their vital signs, their lupus activity, as well as their lupus damage index. And so what we found, I'm not sure why this is not coming up. The point here, and I'm not sure why my slide is not showing appropriately, but there are no real differences between the ages, BMIs, lupus duration, smoking percentage, diabetes, hypertension, or average prednisone dose. And I wish that you could see these numbers here, but the average time period that patients had lupus was about 2 to 3 years. Okay, and so we were in Accra, Ghana, so this is where we were. These dot plots are just showing you where the patients were coming from. So you can see that the majority of patients were coming right around the Accra area, with very few patients coming from the northern areas. And so this is showing the different ethnic groups for each of the patients that we collected. Okay, so these slides are not showing appropriately for some reason. Okay, so this is showing the differences compared to the NYU African Americans and the Ghanaian lupus patients. It's showing you the differences in the lupus criteria. And what you can see is that for things like arthritis, serositis, Ghanaian patients were actually more likely to have disease, as well as neurologic disease. And the Ghanaian patients, so we took their blood samples back to New York, tested them, and we found that a lot of antibodies, so RMP antibodies, Rho antibodies, were actually much more common in Ghanaian patients than in African American patients. Okay. And so this is just showing you, so patients who carried 0 or 1 copies of the variants who are low risk versus 2 copies of the variants, and then the different medications they were taking. So there were no real differences in the medications, but there was a really, there's a high dependence on taking methylprednisolone, so steroids, hydroxychloroquine, and NSAIDs. So those were the most common medications taken in both groups. Azathioprine was the most common DMARD, with the others like methotrexate, MMF, Cytoxan being much less common. Lisinopril was often given to patients who've had nephritis. Okay, and so this is showing the SLIC damage index. And so what this is a measure of how much organ injury a patient has developed over time in the course of their lupus. And so I'm showing here ancestral, so patients who carried no copies of the variants, heterozygous for the variant, 2 copies of the variants. And you can see that patients who had 2 copies of the variants were more likely to have cognitive impairment, more likely to have end-stage kidney disease, as well as cardiomyopathy and pulp loss. And so it's interesting because these are all related to renal disease or vascular insufficiency. And so we ran a Poisson regression model looking at whether or not carrying 2 copies of variants associated with a higher SLIC damage index count. And it did. So just in the unadjusted model, we found that patients who carried 2 copies of variants were much more likely to have an accumulation of SLIC damage. As well, when we controlled for lupus activity over a year's period, we actually didn't see a change. So even controlling for lupus activity, these patients were more likely to have a higher SLIC damage index. Disease duration also did not make a difference. However, when we corrected for renal function, so we looked at the combination of mean arterial pressure, kidney function is measured by EGFR, as well as protein in the urine. And when we corrected for kidney function, we did find that it mitigated the risk. So this was mediated by this effect on kidney function. Okay, so we wanted to look at the urine protein over time as measured by urine dipstick. So we had these patients at each of the visits take their urine protein, and we found that the top line is the 2 variant copies. Middle line is the 1 variant copy, no variance is in the white here. And so what we found is that at each time point, the patients who carried 2 copies of the variants were spilling more protein in their urine, which was a indication of kidney damage. We also found that their creatinine, which the higher, the worse the kidney injury, was much higher, as well as their blood pressures. Their blood pressures were higher as well. Interestingly, their blood pressures were relatively higher than the other genetic groups, but they weren't so high that we would consider this hypertension. And this may be a lesson to us that even in patients who don't have severe hypertension, this could be contributing to kidney injury in the double variant carriers. All right, and so lastly, and I think this is the important point, is that the case fatality rate was markedly different in the patients who carried the 2 copies of the variant. So the white bar are the patients who have no copies, purple 1 copy, the teal bar is the patients who had 2 copies. So a year out, 25% of the patients with 2 copies of the risk variant actually had died of their disease. And these deaths were due to end-stage kidney disease and heart failure. And so this really drives home the point that these variants are influencing outcomes in these patients and also deaths. Okay, and so I want to acknowledge some of my collaborators and also mention that we are repeating the study in Nigeria to see how these variants influence disease in Nigeria. But I collaborated with Dr. Adeji Fade, who is in Ghana. She was one of the only consultant rheumatologists. Now she's got a partner in crime. Our study coordinators were Margaret Reynolds and Festus Ankara. And so in Nigeria, Dr. Olufemi Adelowo is one of our collaborators, as well as Dr. Osola Ayenlowo, and then Fumi and Ronke are our study coordinators. And so I have a number of collaborators at NYU that I would also like to thank, and then also our sources of funding. And I will take your questions.
Thank you very much, Professor Ashira. Thank you so much for that. Do we have any questions for Professor Ashira? Any questions specifically for her? Please send your questions in if you do. Any questions regarding the APOL1 gene? Now, while we're waiting for that, let me just quickly say we've had lots of questions coming in, and some of those questions are being answered directly. So if you check, you'd see, you'd have seen that some of your questions may not be asked live, but they are being answered. And if we are unable to answer all the questions, you can still send your questions into our email at the labalabafoundation@gmail.com. That's labalabafoundation@gmail.com. We will put it up at the end. Any questions that were not dealt with, or if you have any more questions, can be sent in there and they will be answered. So again, some questions are being answered live, and some questions are being answers are being typed. So you can send in your question. So we do have a question for you, Professor Ashir. Someone is asking that how can one get tested? I believe they're asking, how do you get tested for the gene?
Yeah, so at the moment, gene testing is actually on the level of research. So because it's unclear who's going to end up having an issue, given that they carry 2 copies of the gene, and it's also unclear what to do about that risk, research is going to have to progress prior to this being brought to the clinic. And so participating in the studies is the best way to know whether or not you have the gene. but it's not being offered as a clinical test.
Okay. Thank you for that. I think that answers the question. Thank you very much. Okay, so while we just wait, if there are any more questions, they will come in, and I may come back to you, Professor Ashira. We will just move on to the our last speaker for today, and that's Professor Ananda Raja. Professor Ananda Raja was born in Sri Lanka and migrated to Nigeria in 1982. He completed his medical school at the University of Nigeria and did his internship in Benue State. He then moved to the Republic of Ireland, where he completed his postgraduate training before moving to the United States. So he did his specialty training at the rheumatology at the University of Rochester in New York, and went on to join the Faculty of Allergy, Immunology, and Rheumatology at the same institution. He did serve as the clinical director of the division between 2006 and 2018 before stepping down to pursue his clinical and research interests. So his work has led to the development of the IQ Lupus project, which is a nationally acclaimed project, and we are really pleased and honored to have him here with us. Professor Allen, I'll hand over to you now for your talk. Thank you.
Thank you very much for that kind introduction. I first want to thank CHISA and the other organizers for including me in this amazing elite panel of speakers. So my topic is going to be on a very important component of all that we talked about, which is how do we really care for our patients? And I strongly believe that the way to do that is by empowering our patients. And I like to describe it as setting that butterfly free. And that comes from this characteristic rash, the butterfly rash that's often seen in lupus. And as we go along, you will understand what I mean by this. So next slide, please. So I'll start off, which has been really well described by a lot of the speakers before me. This is an article by Tiffin et al. That came out of South Africa, which talks about lupus in Africa. And I know some of the speakers talked about articles that came even earlier this year. But basically the point I wanted to show was that the understanding is that lupus is not very common in Nigeria or in Africa in general. Well, we have heard that that may not be true. And the reasons for that are many. Well, number one is because of underdiagnosis of this condition. And again, we have talked about many reasons why this may be the case. There is problems with access for patients to get in to see a rheumatologist or even in healthcare, to see a specialist. We have already talked about the number of rheumatologists, how hard it is to get to some of these centers that have rheumatologists. I'm excited to know that there are 47. When I was there in the 90s, as you probably suggested there, I didn't know of any, but there was probably one. So that is a huge problem. And even right now for patients in villages to get access can be really hard. We also talked about low recognition of this disease. It mimics other conditions. And unfortunately, a lot of our colleagues, other healthcare workers, don't know much about lupus. It's not only the case in Nigeria, but throughout the world, primary care physicians sometimes have difficulty recognizing this disease, and therefore patients are not referred to a rheumatologist in a timely manner. We have already talked about difficulty in diagnosis, the lack of diagnostic facilities, and the difficulty in getting this test done is another issue that can lead to the low incidence or the reported low incidence. And then the low number of rheumatologists and specialists as we talked about. Next slide, please. So how do we improve this current status? And as I mentioned, I strongly believe that the way to do that is empowering our patients. So what is patient empowerment? It is to make someone stronger and more confident, especially in controlling their life and claiming their rights. How do we do this? Well, my secret is we play the ACE card, and I don't know if you hit next, it might show you, but it's basically the ACE card involves three things: improving access, improving or encouraging community engagement, and incorporating patient education. Next slide, please. So let's talk about some of these things. So let's start with access. So this is a picture of a beautiful castle in the Black Forest in Germany. As you can see straight away, it's a beautiful castle, but to get there is going to be really difficult. It looks like there's a small bridge that gets you there. If you hit next, please. Now, this is a castle built by Disney. In fact, this castle was built based on the one in Germany. And you can see straight away the huge roads that kind of lead into this castle. And if those of you who have been fortunate to get into these theme parks, you can see that it's not just the roads, the airports, the hotels, the whole neighborhood is made to encourage people to get to these theme parks. That's what true access should be. So how do we get there? Next slide, please. So here are some things that we could do to help bridge this gap between our patients and the specialist. I think the really important thing to do is to build community health centers. We need to address the lupus in a way that is relevant to the patient based on their beliefs, based on their culture, based on their education levels, and based on their language. And this can be really hard to do unless we kind of work with the patients according to their interest and not according to what works for us. And then what we do is use patient navigators. This could be in the form of patient peers, or it could be with other health professionals. We kind of have them relay the diagnosis and get those patients from those community centers to come to those few specialists in the various parts of the country. We have to learn to use technology. We are doing that today thanks to COVID. I mean, there are a lot of problems, but here is an advantage. We have to learn to use some of this technology to get access to our patients. I mean, we have already heard this, and I talked to Chisa last week. It's not an uncommon problem where you have patients having to drive or take 4 hours to get to the specialist only to be told, oh, your appointment is not today, or it was canceled because of so and so. This structure of referral and getting patients seen has to change. We have to make it convenient for our patients. We have to facilitate lab testing. I mean, I remember during my time in Benue State, we almost never, I don't remember ever doing a lupus test because it takes several days for these results to come back, and patients who have come from far cannot sit and wait for you to have a test back in a week or probably months at that time. So in general, we have to advocate for our patients. We have to change what's going on. We have to educate our health professionals about the importance of this disease, and we have to change the political system to kind of recognize this is a disease of African Americans and Africans, that it has to be addressed by our community and not by others. Next slide, please. So the C in the ACE is community engagement. I would describe this as a strategic process where we bring people with common interests, in this case lupus, to identify and address issues that affects their well-being. So unfortunately, we know that this probably does not exist in a great level. I mean, I can see already what this organization has done to kind of take it to the next level, but there are a lot of excuses, financial excuses. We kind of say patients don't understand this, maybe educational levels in the villages, maybe the language barriers, but this is something we have to overcome. Next slide, please. And how do we do this? We do this by really enabling community engagement. We have to develop outreach programs that directly engage our community members. This is, of course, it has to include our patients, their family, their friends, and then we kind of organize things that they can be part of. It could be in the form of social events, educational programs, programs where they exercise together, programs to kind of take the stress out. And this will eventually help in the patients themselves getting together and probably forming support groups where they can relate to each other's conditions and help each other take care of the problems. Because as we have already talked about, this is a disease with many symptoms that can change over time, which is best understood by another patient. And try as we may, it's hard for us physicians to understand all the concepts. So what are the things we can do as some of the physicians in various parts of the world? We can help build that network, which is hopefully what we are doing as part of the symposium. We can get our patients together with our physicians, family members, and include community leaders to make sure we address what is important for the patient and not what works for the doctor. Next, please. Last but not least, the ACE, the E, is education. We need to understand that the more the patient understands the disease and is educated on the disease, the more they are able to make decisions regarding their health. Several studies have shown that patients who understand the disease are better able to manage their manage their symptoms. They are much more likely to be adherent with their medications because they understand why they need to take some of these medications that don't make them feel good, even when they feel well. And it also helps the patients better communicate with the physicians, which can be a huge problem in various communities, because the doctors say, well, the patient didn't tell me. Well, the patient doesn't know how to tell them and is doing their best to describe their symptoms. So how do we do this? Next slide, please. So we have to learn to make these educational programs easy to understand for our patients, culturally appropriate, and linguistically appropriate. I mean, it's very hard for patients to come and be overwhelmed by the huge clinics and the big teaching hospitals, and they're not going to say, hey, we didn't understand what you said. We have to make sure they understand what you said. So we have to develop easy to understand educational materials that don't go on for 15 pages, but it's usually 1 page, 2 pages at the most that addresses their concerns. I'm a big fan of creating short videos. I mean, remember, a lot of our patients are young people who just, they don't want to read. My kids who are at 16, I try to fight with them to make them read a book. They want to watch videos. So create those short animated videos. We have them on our website at the University of Rochester, and that's one of the things that I really work on to help create these videos for our patients. Then we can do what we are doing now. We do monthly, maybe quarterly meetings, symposia, where we talk to patients again about what they want, and not always necessarily what we want to say. And then once we do this symposia, we want to build libraries of resources. Just today we had 2 hours of amazing talks. If we can put these together, give it to our patients to discuss and read at a time of their liking and not at a time that's convenient for us. And over time, we build these resources to make it available for our patients. And I think at the end of the day, we kind of culminate this by exchange programs. The previous speaker kind of talked about how she went to Ghana and got things done. I mean, if we have a setup in these various parts of the world, there are so many of us who would love to go there and make a meaningful difference in the short time that we get. I mean, I would love to spend 6 months in Nigeria probably, but I know then I won't have a job when I come back. So at best, I might get 1 to 2 weeks. How do I best do what I want to do and help the community? It's if we have already a setup for these things to take place. So my last slide. So what I've tried to show is that we really need to empower patients and set that butterfly free. How do we do that? I've tried to show you we need to improve access. We need to make that happen and make it convenient for our patients based on what they want. We need to enable community engagement, and we need to incorporate educational programs for our patients. So I want to thank again for letting me be part of this. And I can already say my talk is highlighted by the example of how this was created. Chisa is an example of one patient who has put this amazing thing together. If we do what I talked about, empowering our patients, and if we get 100 Chisas, I'll be without a job. I'll be ready to retire. That's what we need. So thank you again for inviting me, and I'm available for any questions.
Thank you very much, Professor Allen. That was brilliant. Thank you. Especially, it's so important, patient education, isn't it? You know, empower the patient, you know, no matter what the problem is. Once you empower the patient, you know, it goes such a long way. Thank you so much. Someone is asking you specifically whether you have any plans to bring some of your initiatives to Nigeria. I know you mentioned that you'd love to come, but are there any plans currently underway?
I think Chisa and I had been talking about that. Thanks to COVID, that has been put back by some time, but I definitely...
You're being promised pounded yam and beer.
Oh God, now I want to be there tomorrow. I miss both those a lot, and my jollof rice and plantain is my favorite.
Ah, yes. So yes, so hopefully once the COVID situation, once things sort of normalized, some degree of normalcy, perhaps.
I definitely would love to be there, but I think I don't want that to be the place for this to be delayed. I think we have got this started by Zoom. I think let's build a foundation, and then what we would love, I mean, I do this with some of my colleagues in Sri Lanka, and what we have done is we have a visiting program where all of us take 2-week breaks to go there. So there's always somebody in that part of the world either educating or bringing a group of people to
together,
to highlight what we can do. And I think it can be in reverse too. There is so much that the US can learn from Africa that people don't realize that. So I want that to happen too. I think we can have so many people come from there and show people here how to manage their symptoms with more difficulties that they face on a day-to-day basis.
Thank you. Thank you very much. Okay, and now we would, if we can have all the panelists come back on. We have answered most of the questions. Like I said earlier, we were answering the questions as they came, and you know, some of the questions have been answered directly by the panelists that they were directed to. We have 1 or 2 more questions, and some may still come in, but we want to say such a big thank you to everyone who has come to speak to us, all the panelists who have come to speak to us, and a huge thank you to all the attendees who have stayed with us to the end of the program. I have a question here to all the doctors who are involved in the research in Africa. The commenter is saying it's heartening to see that there's work being done in this regard, and is asking whether any of this work is linking up to drug development, and if so, are you able to give some examples? So is Professor Femi or Professor Kala, would anyone like to comment on that?
Professor Femi, do you want to start?
Oh, okay, right. The development of drugs for any condition at all usually lies on the shoulders of pharmaceutical companies. They are the ones that conceive it, they're the ones that develop the molecule in the laboratory, they're the ones that do the initial animal research. But when they get to the stage in which they have trials, that's the stage that the doctors come in. So doctors don't normally develop drugs. It's the pharmaceutical industry that develops the drugs. And don't forget that the cost of developing any drug is so high, so prohibitive, that you need a lot of money to do so. What do you say, Asghar?
I agree entirely,
Asghar?
Femi. I agree with you, Femi. You know, the other thing is that perhaps what we should be encouraging is for these companies to conduct these clinical trials in Africa. So, for example, if you look at a drug like rituximab, which is really a very good drug for lupus, a lot of the data and the randomized control trials were not very successful among Caucasian patients, but it may be a situation in Africa.
Okay. Do we have any? If we don't have any other questions, we do have 1 or 2 questions that would have to be answered directly at a later time. So we've come to the end of the symposium. I'm sure you would all agree with me that it has been fantastic. There's been a lot of knowledge that has been shared and a lot of things to take home, you know, for the patients and the doctors. Empowering the patient again is such a huge one. We were so thrilled to hear from Dr. Etegboje. I thought that that was fantastic. Dr. Etegboje sharing her experience and helping people who are living with lupus, practical tips on what they can do and what their carers can do as well. There is a world of resource. If you follow the Laba Laba Foundation, the Instagram handle is currently on the screen as we speak. You can also follow them on their Facebook page, and you would see all the events as they come up, all the what they are doing, and you know, upcoming events will be there as well. You can also contact them on phone and by email. There will be a new website coming up very shortly, so please look out for that. So there's a world of resource available for lupus, for those suffering from lupus and for those managing patients with lupus. Just reach out if you need to. Thank you once again. And at this point, I'm going to say thank you to our panelists once more. And thank you to our hosts, Dr. Aisha and Mrs. Chisa, for this wonderful platform. Thank you very much, everyone. Thank you.
Thank you very much. Bye.
Thank you very much. Bye-bye.
Thank you.
Bye.
Bye.
Bye.